It's a pleasure to be able to participate in this meeting. And my talk is going to be about implementing cognitive remediation in large systems of mental health care. Let's see. So the reason we offer cognitive remediation is because we're trying to help people improve their functioning in the community. And that's really the goal of all psychiatric treatment. It's to address not just the symptoms of mental illness, but most importantly, to make it possible for people to be able to function more effectively in the community. And we call that functional outcomes. One of the symptoms of severe mental illness that makes it particularly difficult to function in the community is cognitive impairment. Many people with schizophrenia, schizoaffective disorder, psychotic disorders, and severe mental illnesses in general experience cognitive impairment, and that has been associated and as one of the biggest. It's been associated with poor community functioning and is considered a predictor of difficulties getting jobs, living independently, socializing, for example. So cognitive remediation is a behavioral treatment that targets the cognitive dysfunction. And the goal is to improve cognition so that people's functioning in everyday life improves. I'm going to be talking today about efforts to disseminate cognitive remediation in large systems of care. And the model of cognitive remediation that has been used in these efforts is called NEAR, the Neuropsychological and Educational Approach to Remediation. It's a cognitive remediation approach that integrates our understanding of how people learn and how to help them be motivated to learn with our understanding of neuroplasticity and recovery-oriented treatments to really focus on cognitive health. The treatment itself is provided in a group context and usually combines a combination of restorative exercises with group discussion that may have compensatory techniques or focus on metacognition. But the general goal of those discussions is to help bridge what is happening with the cognitive exercises to everyday life. So the goal is to help people actually be using their improved cognitive skills in everyday life. The history of NEAR is that it was actually started in the 80s in New York, and in the 90s it was implemented in a number of different settings in the United States. And then starting in 2000, there was a lot of interest in bringing it in other countries. And so there have been implementation and dissemination efforts in other countries. And along with that came a real need to start providing more systematic training and train the trainer programs, which we then started to develop. And on an ongoing way, we're now working to help cognitive remediation be integrated into large and small systems of care. The reason NEAR works well in large systems of care is because it is very recovery-oriented and skills-based. And so it fits in well with larger programs of psychiatric rehabilitation because there's this complementary focus on helping people manage their illness, restore their skills, and providing the support so that they can live successfully in the community. These are some of the settings where we have been disseminating cognitive remediation. And again, I'll be focusing today more on the large systems of care. For example, in the state of New York, which is one of the larger states and has one of the largest mental health systems in the United States. And so we disseminated cognitive remediation in 13 of the 16 psychiatric centers, which were providing care to about 20,000 adults who were living in rural and urban settings. I'll also be providing some of the data from the dissemination in Japan, where cognitive remediation was implemented in across institutes around the country. 51 institutes participated in training. And I'll also be talking about dissemination in On Track New York, which is a system right now, 23 sites in New York State serving people with early psychosis, first episode psychosis, with the coordinated specialty care model. When you are bringing cognitive remediation into large systems of care, it's really important to consider the outer setting and the inner setting. And I'm going to take a minute to talk about both of those. The outer setting refers to the broader system that is providing the policies and regulations and fiscal oversight for the individual centers. So in New York State, for example, that is the central office for New York State Office of Mental Health. In other countries, there may be a centralized government structure which provides the policies and regulations for mental health. Within that outer setting, there needs to be support for addressing cognitive health and more specifically cognitive remediation. So there has to be a very clear message coming from that centralized outer setting that addressing cognitive health is valued and that there is support for these cognitive remediation programs. The inner setting refers to the particular program where a client is going to access the cognitive remediation. And it's important that within that particular setting, there's a perception that bringing this program in, bringing cognitive remediation in, is going to address a felt need. So usually that is expressed by clinicians and patients as we've noticed that cognition is a problem. We've noticed people complaining about memory and attention. We notice that people are struggling to be organized. So there has to be some felt need that cognition has to be addressed in order to help people function better in the community. The cognitive remediation program also that's being proposed also needs to be able to fit into the program structure. It's not going to work if we bring in a treatment that requires staffing or space or technology that just isn't available to the program. So there has to be a workflow or program structure, processes, and resources, particularly time and technology, available to support the cognitive remediation program. And more generally, it's really important that within this inner setting, there be a culture of change and openness to bringing in a new program. And part of bringing in any program is also building in program evaluation, which can allow for, in this case, the cognitive remediation, to always be up to date and sensitive and responsive to the needs of the participants. So within program evaluation, you see that first there's an effort to evaluate how is it going. There's data generated, and then there's an adjustment made based on that data. Adjustments can be made to the practice, so that we are constantly then having a cognitive remediation program that is relevant to the needs of the stakeholders. I'm going to be talking about some of the program evaluation initiatives that we had at in New York State. And most of these initiatives focus either on engagement into the program or outcomes. So one of the first questions a person might ask is, when you train sites, when you go into a large system of care and offer training to set up cognitive remediation programs, do those programs actually get set up? And we call this uptake. And the question is, if you're giving the clinicians the training and you're getting central support, you're providing them the resources so they can actually set up a program, does this program begin? And what we found, and this was in New York State and also across the Japanese sites where there has been a huge effort towards implementation and dissemination, across these varied sites, we've seen about a 70% uptake, meaning of all the sites that got trained to set up a program, 70% of them actually had a program up and running within a year. There are various reasons why uptake might not happen. So some of the biggest reasons are changes in leadership or fiscal or in the funding. Some other important questions that are relevant to the engagement process is, when you set up a cognitive remediation program, do people actually show up for their appointments? Okay. And we call that utilization, and we measure it by the percent of times that you schedule an appointment when somebody actually shows up. So this is a group therapy. So we have a number of people being scheduled to show up at any particular time. And what we find across these many sites is an average of about 70% utilization. Is this good? I would say it's okay. A good amount of utilization is really when you get into the 80s. And we see quite a range in utilization. Some programs are in the 60s. And I would say that when utilization starts to get in the 60s, there's really should be sort of an attention to what can you do to improve the situation and to head utilization back closer to the upper 70s and 80s. There's always going to be missed appointments. The weather could be bad, transit doesn't work, the person's sick. But we would always aim that most of the appointments would be attended. Another question is fill level. If you are trying to offer 6 spots for a group or 8 spots for a group, are you able to keep those spots filled? And this is important because you have clinicians spending time, you have computers and resources. Is all that being utilized? So again, across the many sites, what we found is over 60% of the sites were able to keep their fill level over 80%. In other words, 80% of the spots were being utilized. Another question people ask is about treatment fidelity. You train clinicians to do a treatment. Do they offer the treatment as they were trained to? And built into this model are scales to assess treatment fidelity. They're widely available in the book and in the clinician manual. So for example, I have a picture on the slide here looking at the structure of the treatment and the session organization. And what we found across sites was that greater than 80% treatment fidelity was obtained. In terms of moving to evaluation of outcomes, so when the clients are engaged in cognitive remediation, In this case, we asked, does it improve engagement in activities within the clinic? What did we see as evidence of improved engagement? And these are some of the data from 8 clinics. And what you could see, the 63% of the clients started to show more self-confidence in their, this was evident while they were participating at the clinic. 52% of them started to participate more in the discussions. 47% of them showed increased sociability within the program. 36.8, almost 37% started to be more assertive about their needs. And close to 16% started to attend more programs within the clinic. And what about whether participating in cognitive remediation actually improves community engagement? Again, looking at 8 sites, what we saw was 50% of the clients at the end of 30 sessions of cognitive remediation, 50% of the clients started to be more engaged in the community. They were doing more activities within the community. 40% of them started to work. 25% of them started to do more at school, and 40% of them made improvements in their independent living. In terms of satisfaction with the program, and this was a study that was actually led by a postdoc from France, and the references at the bottom. So most of the clients participating in cognitive remediation were pretty satisfied. As you can see here, most people found that the overall experience was good or excellent. 95% of them felt like it was impacting their cognitive skills, and 90% of them thought it was helping them with their functioning. And these are sort of the examples of some of the comments people make. Exercises were rewarding. I'm able to retain things better. It's helped me relate to my friends, and so forth. Now, I also wanted to talk about cognitive remediation as it's delivered virtually, which is something very relevant now as we have a pandemic. And it's extremely relevant also when thinking about how we can provide cognitive remediation to people from diverse backgrounds. So we did a study recently where we asked whether cognitive remediation also works when delivered remotely. And we did this within public clinic settings where the socioeconomic status of the participants tended to be lower. So some sessions were offered to people by a clinician twice a week in the clinic. And we were getting a lot of complaints that people wanted to just come once a week. They were asking, how come we can't come once a week? So in response to that barrier of multiple sessions, requiring multiple sessions to participate, we did this study. And in the study, we had 62 participants, and they were at 6 sites. And they were enrolled in a trial where they either came to the clinic twice a week for clinician-led sessions, or once a week, and then they had to do their homework independently. We called that remote. And we did surveys of their familiarity with the technology, their access to technology. And we were able to do interviews with some people about what they saw as the facilitators and barriers to doing remote CR. The people who participated in this study were of a diverse racial background. Most of them had about 12 years of education. That was the average. The majority were male. Most were unemployed, and most were getting assistance with their living. Only 30% had independent living. So of the people participating, and this is, I think, really important for people to keep in mind as they make this treatment available more widely. In this sample, only 67% of people reported they had no access to a computer at home, so they couldn't do the exercises at home. And 64% of them said they only use a computer once or not at all during a week. If you think how much you use a computer, this is a really very different. The majority of people are not using computer very much. And 20% of them acknowledged having a very low proficiency with computers. In our qualitative interviews, what we found is that a huge barrier to doing cognitive remediation remotely was the lack of access to a computer and a lack of computer skill. So without access to a computer outside the clinic, most people were coming into the clinic to get access to a computer. This was really different from what we saw in a clinic that was serving people with a higher socioeconomic status. In that clinic, 90% of the people were able to immediately participate in remote CR because they had access to a computer, they had privacy, and they had the know-how to participate with the technology. This was not true in the public health setting, where the majority of people did not have access to a computer, and there was much more limited facility with the technology. These are some of the themes that came across in the interviews of clients and staff in the public health, in the public sector settings where we were serving a lower socioeconomic status. There was a repeated request to make computers with internet access more available to both clients and staff. It was very difficult to conduct the treatment without improving that access. Even within the clinic, we were hearing about limited infrastructure, both in terms of the technology and the space. And we were hearing repeatedly about the client's struggles to actually use the technology and their need for support. However, we did note that when clients were able to access the technology independently and participate independently, they appreciated the independence and their sense of accomplishment. We saw a wide range of need for clinician support in the public sector. Some people needed quite a bit of support with technology and others less so. It was interesting that there was also a wide range of interest in participating in a group. Some people really liked having some time to work alone on cognitive exercises, and others really appreciated having a meeting in a group. I think the overall message here is that there's no one way to do cognitive remediation that's going to work for everybody, and that remote cognitive remediation works best for people who have access to technology, the basic computer skills, privacy, who have a need for flexible scheduling, and an ability to work independently. Since our overall goal in providing cognitive remediation is to help people function better in the community, it's so important that cognitive services involve shared engagement in that therapeutic process, and that the clinicians are conveying a sense of empowerment and hope to the participants. At its core, cognitive remediation is a recovery-oriented, strengths-based, and patient-oriented practice. And we use neuroscience to then improve cognitive health. It's so important to consider how we can personalize the treatment so that we can best address the needs of a diverse clientele. I want to thank the many people in the United States who have helped with these particular projects, and also to just provide some information about resources that are available to people who want to learn more about cognitive remediation. there's books and handbooks, and there's a conference, and there's websites. And I'm going to end there, and thank you very much.
Thank you very much. It was great, and the timeline is wonderful. So thanks for this.
Thank you.
If you're okay, maybe we can just have one extra question to sum up maybe what you just told us, because it seems that the question we had, you have already answered in your presentation. That's very great. Maybe the one that if you can provide us with the main components of an efficient cognitive remediation approach, especially for people in economic and social distress. What would you say? You just told us about the limitations in access of technology for people with low economic status. But maybe you have identified other constraints and some protective factors maybe to provide this kind of approach to vulnerable people.
I'm sure that's a really great question. I think from a scientific standpoint, we have to consider how we're going to provide people with enough opportunity so that they can amass practice on cognitive exercises, because they have to have sufficient exposure to the cognitive exercises so that they actually can make improvements. And we also want to give them sufficient exposure to the bridging exercises and to the discussions. So it's important that people have adequate time and access to the technology that's going to allow them to do that, and that they have adequate exposure and time with the clinicians who can provide them with the support that they need. And right now, there's numerous barriers to doing that, particularly for people with economic and social distress. So we need to raise awareness about the lack of availability of technology. I think that it's easy for many people to forget that not everyone has access to the web and to technology. So there really needs to be more work done making technology available to everyone. I do also want to note that there are some extremely helpful programs like the one developed by Beth Twamley that provide an alternative approach to doing cognitive remediation in resource-poor settings. Her program does not require that people have access to technology. However, from an equity and disparity standpoint, all people should be given the same opportunity. So I would hate to see a situation where compensatory approaches to treating cognition, like the one developed by Beth Twamley, becomes the mainstay of resource-poor environments, while restorative approaches that rely on technology are thriving in the more economically advantageous settings. That would be setting up an inequity. So we really do need to work on making both kinds of treatments easily available to everyone.
Thank you.